Other than that, both we are streaming.
Thank you. All right. Hi, everyone. My name is Safiya Tisdell. I'm with Nexus Health. I'm the VP of our Adparo services over there. So, of course, our favorite topic, denials 101, right? So, what does that mean? That means so many different things. So, you did everything right. You've gone in, you've gotten your authorizations, you've done everything, and then what happens? Let's learn a little bit about it, I think. Let's see. So, a couple of common words when you hear of denials: prior authorizations, benefit investigation, coordination of benefits, predeterminations, medical necessity, step therapy, NDC number missing, incorrect units. These are some of the common reasons you'll typically see a denial, unless someone else has any other common denials that I missed out here. So, but these are the most common ones that I know. So, let's try to take it back. Like, what happens at the very beginning? How do we even run into denials? So, first thing we do a pre service review. We have a claim scrubber that scrubs all of our claims to make sure, did we get everything right on the front end? We do coding charge capture. We do EDI claims processing. Oh, that's what it does. Okay. Then claim goes out, wonders of something, and then that's when we come back and we have our denial management, AR follow up, payment posting issues, reconsideration, and then final end of it, appeals. Well, we hope to end with payment, but usually that's where we kind of end up. So when I say pre service review, what is that? That's your order. That's your physicians, your NPs, your APPs placing an order. They're doing a prescription. So typically we're going to talk about infusion services. So order entry, benefit investigation, identifying the right benefit, right? That's one of the most important parts of it. Is it medical? Is it pharmacy? Is it buy and bill? Where do you get this drug from? Then to figure out that the authorization is required. But wait, it's not required because there's no guarantee of payment. So you can get told that on a recorded line by the insurance companies, no guarantee of payments. What am I doing all this work for? What's the point of it? So you think, all right, I'll just do a predetermination because then at least I have something in written documentation that says I'm going to get paid. But wait, because you're going to get lucky and you're going to Get that predetermination. You're going to get an authorization. You got a reference number, a case number, all of those things. So then you go through all of it, you get your approval, and then here comes our denied. So, of course, they sent you that documentation. We don't know where it is. The EOB got lost, all of those different things. So, what are typical reasons of denials? Like we kind of talked about earlier, we have lack of pre-cert authorizations. Because guess what? A new J99 came out, or a new drug got a new J code that we had no idea of. Now it requires pre-cert. Invalid diagnosis, medical necessity, requires additional information, non-covered service on plan benefit, out-of-network provider. How about that one? Billing errors. So either the NDC number's wrong, or your units are wrong, or it's investigational, or this is the worst one of it all because there is no turning it around. Timely filing. Because, oops, we made a mistake. That claim sat there in some scrubber and we just can't get it paid. It just wants to keep jumping. So let's identify that. We review the EOB and denial. There's so many different codes. Me and my team actually yesterday were looking up a random denial code called GK. What is GK? Because there's so many different acronyms. So you Google, you try to figure it out, you try to look at the description of the EOB, but typically it just says member responsibility. Well, let's do a little bit further in that. It's common for accounts receivable team to just auto appeal. This is one of the most common mistakes in denials because your team will say, oh, I got a denial. Let me just take the entire EMR from this date of service to that date of service and submit it. Well, I know one specific payer that absolutely will reject that and say, oh, you sent me over 12 pages. I want nothing to do with this. You've missed your level 1 opportunity. You've missed your reconsideration. So don't do that because you're losing that. But you need to review your denial. You need to identify what is the core problem before you go ahead and apply for it. So what do we do? Coding errors. Those are one of the easiest ones to fix. Get your NDC number right. Get your units right. Get your diagnosis right. And instead of resubmitting or reconsidering, just resubmit the claim. Void the claim, resubmit it, get it out the door. Then our favorite one, which a lot of times we don't have control over, is a COB. What's COB? Anyone? Anyone? There we go. Coordination of benefits. So unfortunately, people that aren't in our world will typically go and get on their husbands or their spouses or their wives' insurance, and then nobody calls the primary payer to say who's going to be primary, who's going to be secondary. So that happens, and well, we're going to get a denial now because guess what? There's a secret code in your HICFA, in your EDI claim that says there is another payer on file. So you'll get that rejection. It'll come back and say, this patient has a different insurance, so I'm not going to pay you. Another reason for me to not pay you. So this patient is your first advocate. They're the ones that are going to have to help you reach out to the payer, get that resolved. A lot of times what we've done in the past is do a three-way call because patients don't know how to do this on their own. You're their advocates for them. So let's get on a call with them, do a three-way call, and make that happen. Out-of-network denials. Those are no fun because of the fact that you did your due diligence on the front end. Well, the patient is now cycle 3, day 7 of their treatment, and they changed their insurance. It did make a full circle back to your benefits coordination, and now you're getting a denial. So, unfortunately, you have to verify the benefit coverage prior to the service to confirm details. So with that, of course, referrals are another one. How many specialist referrals? All of these denials are based on specialist referrals. Humana's, so many of the Medicare Advantages now require those referrals. So get your documentation, Now, if a prior authorization was missed, there's an extremely, which I think is getting smaller as I speak, to get that retro authorization. It used to be where you could just pick up the phone and be like, oh, I'm so sorry, this patient came in 7 days ago. Let me get a retro authorization. I think now the common is maybe 12 hours or 24 hours because most payers just, and most of them will just say, oh, so sorry about that. We hate that for you. So that's unfortunate. But timely filing, that is a sucker because of the fact that you missed your timely filing. But there's still things that you can do. You want to try to resolve this as soon as you identify it. You want to get to the bottom of it and figure it out. So I have one golden rule. This is my golden rule. Notes. If there are no notes, whether it's an EMR system, a practice management system, it's like it never ever happened. Because every call you get on with the payer, they typically say, this call is being recorded. Well, I've tried to call back and say, can you pull up that recording? Nothing. Nothing. It's like, wait, what? What? Okay, all right. So I typically try to do this where you get your name. So I always try to get last name because guess what? There's so many Joes. There's a lot of Joes. Well, we need the initial. Reference number, time, and a phone number because I'm sure you guys do call Cigna a lot. Well, you have to call Cigna. You have to call this person. You have to call that person. And there's about 4 different strands of calls. Well, what number did you get this authorization with? So levels of appeals. So now let's try to identify and figure out what can we do. So there's typically 2 levels of appeals after the reconsideration level. So reconsideration, I typically don't consider appeals. They're mixed in a little bit, but it's where you can submit medical records, you can call the payer, and or state your facts. What's going on? Most likely it's an error because you've done everything on the front end. Then there's a level 1 appeal, which is your internal review administered by the insurance company. So this is them going to their medical director. This is them submitting everything, but you still get a denial. Then you go to that level 2 appeal, which is external review administered by an independent third party. There's tons of payer groups out there, and they all go to the typical same parties that end up denying that same claim. So some errors are resolved with a quick phone call to the payer. You almost don't even have to submit anything. You never have to submit any medical records, but it just gets resolved. But here comes our bad word again. Watch out for those timely filings because even with appeals, each payer has a timely filing limit for appeals. If you miss that, well, you could have easily resolved this with a phone call, but now you've missed that opportunity as well. So to get an appeal in, what do you typically need? So writing a letter for reconsideration, explain in detail for medical necessity, why is this patient getting this treatment? Why did your physician or APP start them on this treatment? And if needed, ask your providers. They want to treat this patient for a reason. They have a reason. Let's go to them and ask for that letter of medical necessity, commonly known as another acronym, LOMN. So submit all medical records. This is again going back to that first thing where it's so common to submit everything. People are busy. They're appealing hundreds of claims a day. Well, you basically don't need to print out every single thing. You need to print out relevant things. You need to print out the right progress note, the right pathology, not the pathology from 6 years ago, the one that's relevant today. So let's print that, progress notes, labs, scans, medication summaries, pathology, demographics. Demographics page, believe it or not, is so important because if you don't submit a demographics page, you will miss out on it. A lot of times they can't find the right Joe. They will find the wrong patient because it doesn't have their insurance card on it. And again, don't submit the entire medical history. If you submit too many, payers will deny it. They will automatically say, this is over my limit. I'm not submitting it. So drug denials. As soon as you receive a denial, which is interesting because I heard some conversations today, as soon as you receive that drug denial, use your manufacturer programs. Use them. Call them. You missed it for a prior authorization. In the back of your head, it's not going to work. But pick up the phone, call your FRM, call your different vendors, and see if there's anything you can do. Use different portals, use different vendors that your team has subscribed to. That is going to be able to help you find those forms. For example, at Annexus Health, we have platforms and you can search a code which has got that exact information. It'll take you to the program's portal. So use vendors like that. We're here to help. But there's so many different reasons of denials. Use those manufacturer programs. Get that patient enrolled immediately. So manufacturer programs can help with appeals process, cover off-label treatments. Again, documentation is key. Work with your FRM, work with your access manager. This is a typical example of what a manufacturer website looks like. So you've got your letter of medical necessity checklist. They're doing the work for you. Do that checklist, sample letter of medical necessity. These are my favorites because you can basically pre-populate the patient's name and the physician's name, and it's a done deal. Prior authorization checklist, appeals checklist, sample letter of appeals, and then sample letter of requesting formulary exception. You've got these tools. You need to use them. A couple of other resources, which some of you guys are probably aware of. Your provider services manager. Those are so important. We used to have a monthly meeting with each one of our large payer groups because they're going to be your advocate. They want your business. They want you to keep seeing their patients. So people like Blue Cross, Cigna, Humana, to name some of the bigger ones, have your provider rep. Use them. Give them a bulk spreadsheet and say, hey, help me with these claims. They're being denied. Field reimbursement managers, I kind of said that already. Community resources. Reach out to the vendors you meet here today or tomorrow. We're here to help you. Department of Insurance. I've had to reach out to them 3 times in my entire career because we've had some serious issues. So I want to make sure that you guys know these tools. And we're here today. We have other resources. I'm happy to kind of give you further details into it. But I think overall, that was kind of everything I wanted to go over. Again, denials 101. This session can go on forever and ever because that's just 101. So I want to make sure that if there are other questions, I'm happy to answer them, group setting or individual settings, because there are no simple questions with denials. Yes, ma'am. Yeah. Nursing home for real knowledge that was happening. I was hired because she was placed in nursing home. She wants to go to rehab. Insurance is denying her the rehab opportunity because they think she can't do it. Yeah. So she's literally in a skilled nursing facility, nursing home, doing rehab level of care, showing them that she can do it and withstand 3 hours a day of therapy. Yep. We're documenting, showing that she's doing it. But they have not actually officially denied her yet. Yeah. Any advice for what to do in the middle? We've already written a letter. We've already submitted all the information to the prior approvals. Any other thoughts? Yeah, skilled nursing facility is one of the hardest things to get out of because those are just Medicare starts coding them incorrectly. And Medicare. Oh. Exactly. Thank you. Well, see, it's a room full of gasps because insurance companies do this. Can you reach out to her provider rep? Is that okay? She's very glad with me. We are waiting for. One of the other folks asked, "What insurance is it?" Just out of curiosity. I mean, again, insurance companies will look for any and every reason to deny. And so you almost have to keep doing that. And you have to come to these type sessions and ask questions because someone knows the answer. Mm-hmm. I can reach out to someone else as well and get your contact and see if there's. Yeah.
But that's what the initial denial was.
Mm-hmm.
But it was an NP over Labor Day holiday. They didn't realize they were on call. Like the gas thing is so great.
I mean, you're on the right track. All you can do is unfortunately use your patient as the advocate. So I think you're on the right track, but I think provider rep is going to be another aspect of it because I think when patients start calling the insurance companies and say, I can't be seen by my physician anymore because you won't approve this, sometimes it rings the right ears. So keep trying. We're here.
I'll have an answer by the end of the day.
We look forward to it. We need to have a session, like a redo just for you then. So, all right. Well, any other questions or thoughts? Denials are no fun. I promise you that. So we just wanted to take a few minutes to talk about it. All right.
Yeah.
To be able to sit in on my presentation on